Welcome to Sports Doc Talk. I'm Will Sanchez, along with our orthopedic surgeon and sports medicine specialist, Dr. Garcia, always blaming me for some kind of technical difficulties we have, but we'll get into that later on. Dr. Garcia, how are you? What's going on? How was your trip to Brazil?
It was good. It's a long, but I got to see my roots. That was my first time in Brazil, so that was pretty fun, and the race was awesome. But I'm now recovered, so I'm back on the Seattle time zone, so that's the most important thing.
All right. Well, we're glad to have you back. And before we bring on our guest, we would like to handle our business because, Mike B likes when we talk about him. Let's give a little talk about Mike B in the recovery shop there.
Yeah. So just again, a shout out to them. Thanks to our sponsors. Again, I've just, patient today, same experience. So post-surgical recovery, looking for, solutions and what they can do after surgery. And so the ability to have these sort of aftermarket products all in one spot works really nicely for the patients as sort of a menu. Hey, do you want to enhance it with this, this, or this? And they've been great. So contact Mike B. They're awesome. If you're a surgeon, you can use them to your benefit in the sort of recovery process. And the patient satisfaction level has been very high. So thanks, guys.
Yeah, thank you, Mike B. We appreciate all the love. Let's get right to it because this man, I believe, is on the East Coast. We're keeping him late. Let's bring in Dr. Greg Kolovich. Dr. Kolovich, hey, first off, thank you for taking time to join us. We really appreciate you being here. How are you this evening?
Good. Thanks for having me, guys. Yeah, I'm on East Coast time, but everybody's asleep, so it's a nice, quiet evening for me.
Oh, nice.
That's great.
So again, to introduce, again, you went to, looks like med school, Ohio State, and then hand fellowship in a low-level place called Harvard, and then, you did your residency training there in Ohio State.
Yep.
And then now you work in Savannah, Georgia. Is that correct?
Yes, sir. Yep. I'm in private practice in Savannah, Georgia. We have a 25 surgeon group, and we cover pretty much all southeastern Georgia and then up in the Hilton Head, all the way down into Florida, and then as east to Macon and the southern outskirts of Atlanta. So we awesome. Cover a wide variety, but multi-specialty orthopedics.
Awesome. And then, you also, one of the reasons we're going to talk about tonight is you co-founded Micro C, which is now, I don't know how you say, Oxos.
That's right. Yep.
I got the background.
Yeah.
Nonetheless, so we want to get into that. But I think before we start with that, will you kind of talk about, you're engineer by background. Mm-hmm. So how did this sort of engineering student to orthopedic surgeon cross over, and kind of what was your reasoning for that?
Well, so engineering, I went to Georgia Tech and I was an electrical engineer, and now I'm an orthopedic surgeon like you. So you can attest to the fact that orthopedics is very much engineering in practice. It's not always algorithmic. You have to sort of ad lib and use creativity. And engineering has always taught me how to think outside the box, how to use different techniques and tools to get the job done, because it doesn't always go the way you draw it up. And I think that really led me to a career in orthopedic surgery, because it's, orthopedic surgery is really engineering in practice. But there was that sentinel moment. I was an engineer, and I started dating a girl who was pre-med. It always has to be about a girl. And
there it is.
Right?
There it is.
So to get in her good graces, I was always struggling to pay, rent and dues and tuition. So we got this job doing organ procurement for a company called LifeLink. I'm sure you guys have out on the West Coast, but they do all the MTF tissue stuff.
I know who it is. Yep.
So you get called in the middle of the night, and you'd have to go out and just harvest tissue and bone, and it was kind of gruesome, but it paid a lot of bills. It paid well, and it got me really interested in anatomy. So then I started taking, as part of my engineering credits, I also started taking organic and inorganic, and then I took my MCAT. But I was an engineer, so I scored really well on the math and physics part of the MCAT. It was the biology part that I struggled with. But yeah, it was always about a girl. And then I was doing what's called co-op. And so you work a semester and then you go to school. And I was working for a company, and we started this cool idea and couldn't really patent it because we were just co-ops. And basically that idea went and sold for a bunch of money and we didn't get anything. So at that point, I was kind of like, I want to work for myself and not get screwed by the big company. So I really wanted to do something that was that I had more autonomy, and I was already doing medicine. So those kind of converged, and then I switched paths from engineering to medicine.
And then in your background, I know you do hand surgery. I mean, microvascular. Tell us about your specialty that you do, what you specialize in, and kind of the stuff that you see on a day-to-day basis.
Sure. So I do hand surgery, but I also do free tissue transfer, microsurgery. I do a lot of peripheral nerve. I'm sure in your practice you find everybody does trigger fingers and carpal tunnels and cubital tunnels and those kind of things. I really wanted to separate myself from everybody and do something that no one really wanted to do. Peripheral nerve is something that not a lot of people have interest in. It can be difficult. I do a lot of nerve transfers, nerve reconstructions. So I'll do anything from like a brachial plexus to Oberlin transfer to Bertelli transfers in the hand. Basically anything that is like iatrogenically a problem, axillary nerves that are injured during total shoulders. I do nerve transfers and I'll do tendon transfers. So I do a lot of complex stuff. So I get a lot of second, third, fourth opinions, desperate cases where a lot of people said there was really nothing left. And I usually come up with a plan for it. So that's actually another part of using engineering. Basically someone comes in with a horrific injury. You got to find out what they have and then sacrifice what they have to give them something that they need. And really at that point, it's about adding functionality to their life. I'll give you an example. I did a reverse Bertelli transfer where you take, this is for an ulnar nerve palsy. We try to add pinch. This is Bertelli 2, where you take the deep branch of the opponents and transfer it to the deep branch of the ulnar nerve to give them more first dorsal analysis and adductor pinch. And that can be a big game changer for someone who has an ulnar nerve palsy, or someone with who needs to get elbow flexion. You can do an Oberlin transfer, stuff like that. Axillary nerve injuries are big. There's all kind of transfers that you can do to sort of give them that forward elevation. And then my peripheral nerve interest has really gotten me into the leg. So I do a lot of common peroneal nerve stuff, sciatic nerve, piriformis releases. I can go anywhere and anywhere with nerve.
That's awesome. Well, I mean, those are big things. I mean, we in orthopedics, and I like the point you made. It's interesting, right? Because you said you're private practice, but you do complicated second, third, fourth opinions. So I like that because obviously in my practice, I'm private as well, and do complicated stuff like the osteotomies and meniscus and cartilage transplants and things like that not as many of the people in the area want to do. So the idea behind that's interesting. I mean, it probably took you a little while to build that practice, I would imagine, in that area, or maybe it was easy because no one wanted to do it. I don't know.
Nobody wanted to do it. So, I mean, when you got to be affable, available, and able, right? And able is probably the least important. Just be available. Private practice is a different animal. A lot of my friends and colleagues work in academics. I feel in private practice, you really, it can be extremely rewarding, but it can also be very challenging because you don't have a big organization with deep pockets supporting you. So
going into that safety net, right? With the private practice, you're missing that safety net from maybe if you were in a private practice.
Yeah, well, you can't really say no. I remember one of the first things I did was I got a call randomly on like a Saturday, and it was an infected olecranon from another doc. But the primary care doc actually called me and said, would you be willing to take over care? And I was like maybe 6 weeks into my practice. So I just took it, right? Complicated osteomyelitis of an elbow in a young person. Okay, I took it. Went in, grafted it, put antibiotic beads in it, got it to heal. That doc has sent me patients for 10 years, like nonstop. I mean, just so thankful. And then of course, taking self-pay Medicaid, you don't put up barriers. So you just send it. No one ever asks what insurance I take. I take all comers because in the end, I always find it frustrating when my partners sit there and nitpick about what insurance the patient has, because in the end, you're going to have some workers' comp that are going to pay really well, and you're going to have some people who are not going to pay well. In the end, it's all going to, if you just keep the ball moving, it all works out in the end. And the idea is it's just do good patient care. And in the end, the outcome really matters. So I stopped nitpicking about insurance or about this or that. My phone, everybody has it. I give it my cell phone all the time. I'm happy to do second opinions. I know some of my partners don't see second opinions, and I find that you're never too advanced. You're never too comfortable to do second opinions, because some of these patients really need help, and sometimes they just need a second set of eyes to see whether they're falling down the right path or not. And just give them 10 minutes of your time. It's not a super difficult thing to do. You can always say no if they can't help. Help them.
Yeah.
So yeah, just being available and being able to be a resource for people to go to has really helped me, because I don't have a steady, some of these hospital systems have hundreds of primary care doctors and ERs that are flooding their referral. I don't have that. So I had to go out and give, go door to door, knock on doors, send Christmas cards, do people favors. And in the end, you get this point where you're established, and it just kind of flows steadily.
Do you want to, Will, can you pull up that slide? I want to know more about this, because that might have to do with sort of the giving back and stuff that you do. Will you just talk about this a little bit more?
Sure.
Slide?
So these are a couple film pictures. One of these is from a couple missions that I did. Part of that is in a country called Eswatini, formerly Swaziland. Mm-hmm. We've been to Kenya. We've been to Ethiopia. We've been to India. One of my partners has an orphanage in central India in a place called Salem, which is in the middle of nowhere. So we used to go there. We do a lot of mission work. I went to Honduras every year in residency with a program called Podemos. So mission work has been really, really important for me and my family. You can see that central picture right there is my oldest son now. He was young back then. He's 13 now. He's he's actually taller than me. There's my wife. He comes too. But on the left, that's us doing microsurgery. There was a machete injury. On the right, I believe we're doing something up in the brachial plexus. It looks like it's an upper arm.
Looks complicated.
There's the clinics, right? You can see these patients come from far and wide. We would have 500-600 people just show up randomly. And, you work, it's exhausting. Anyone who's done mission work, I hope you guys have. It's exhausting. You work 18, 19-hour days. Sometimes you work by candlelight, literally. And it's probably the most rewarding thing you ever do. You realize that you realize the incredible power that you have to help people. Oftentimes we don't see that in our day-to-day clinics. People can become very entitled in our world, but in the dark part of Africa, where some of these places don't even have electricity. You can see our handheld battery-powered X-ray right there. There's no electricity in that building, so we brought our X-rays. It was really helpful. There's one in the locker room, so that's our Optos machine. But
Dr. Kolovich, we talk about mentorship a lot of times on this show. Usually there's been an inspiration, and it could come from different areas, different people. With your diverse background and everything else that you're kind of doing within your organization, what has been inspiring, or who has inspired you to kind of take the baton and keep setting the ground rules for the way you go about your business?
Wow, too many. I could name names. Jesse Jupiter was he's one of the most published surgeons in not just orthopedics, probably in all of medicine. He would just give me advice all the time, and sometimes he never lets the fellows scrub in, and he would let me do the case, which I was really happy about. And he's not one to give easy compliments. And at the end of my fellowship, he said, "Kolovich, you don't annoy me." And that's probably the best compliment I ever got from him. But at that time it was a big deal, because he would never give easy compliments. And then later I was the president of Georgia Hand Society, and he was one of my first speakers. I still see him at meetings. A guy named Dr. Michael Ruff was the head of hand surgery at Ohio State. Really took me under his wing back when I was, I think I was probably a first or second year med student. I would basically come in on Sunday mornings and just kind of sneak in and scrub in and do these. He would do these latissimus flaps and these complex things. I mean, all the stuff that would take 9-10 hours. We'd be in there with plastic surgery fellows and orthopedics, those big cases. And I remember him saying to me, he goes, these are orthopedics. And I asked him why we were doing these micro cases. He goes, this is just, we were in the Midwest. So it was a farmer who got sort of a horrific injury to his upper extremity, and we were just covering him up and doing some tendon and free flaps. And I felt like he was this X-Man. Like he was just doing stuff that no one wanted to do. And he was kind of the doctor's doctor. And he walked around with like such a sophistication, and like he wasn't like pompous or anything. He was just like the man. And I remember thinking like, this guy's coming out on a Sunday, not on call, just loving his job, loving his family. And he was a big mentor to me. I mean, there's so many, you know, God, I mean, I remember, I really appreciated people that were good, but they didn't have to sell it. You know what I mean? I'm sure you guys have come across people like that. Everybody knows who the best surgeon is in their group or in town. And oftentimes it's really exciting when that person is not the one who's, you know, broadcasting it. They just walk around with confidence, and they tend to be really good, not only in their practice, but also in their life. They love their family. They spend time in the community. They do other things. Those are the people that have always, and I can name 100 names of people I've spoken to. Those are the two people that really sort of steered me into hand surgery.
That's awesome. Will you tell us a little bit more about kind of your day-to-day practice, like your day in the life? I mean, you're doing these kind of crazier cases, you're taking on hard things. I mean, are you kind of situated in one office? Do you move around? Like, how does it work for you in your practice? And we'll kind of get into your aspirations outside of medicine.
Sure. Well, I started like everybody taking level 1 trauma call. There weren't a lot of hand surgeons who were doing replants. I started doing that and actually upset some of the people in my town for doing that, because I just came from Mass General where we were doing a replant every night. I mean, every night. Every night you would do some sort of replant or reattachment or revas. So we got so used to it. When I went into private practice, I would just accept everything. And when I started doing that, my town in Savannah was getting sort of known for accepting this thing because of me. And some of my colleagues, not so much in my group, but other people were getting upset with me. And I realized I was sort of upsetting the herd. So I sort of backed off on that and kind of did it sort of more word of mouth, because I still wanted to do that stuff. But in private practice, you have to go where the patients are. So our group is pretty big. We own 2 surgery centers and a hospital, and then we own about 17 satellites. So I like to spend one day traveling because I think it's nice. It's funny. So on Wednesday, I go from Hilton Head. I have a clinic in Hilton Head, Bluffton area, which is a lot of retired golfers, a lot of well-to-do people. And then I immediately go down to Statesboro, which is a college town. And then I get into Reedsville, which is a really rural country town. And you'll see these really like, salt of the earth farmers. And then these really like super end, like Wall Street VC, just on the same day, and to see everyone in between, it's kind of, it's a spice of life. Variety is a spice of life. So seeing patients from all different backgrounds is sort of fun for me. I don't stay put in Savannah just because, patients are getting more sophisticated. They want access. They don't always want to drive 2-3 hours. So I do meet them halfway in many cases. So, I stay in Savannah, probably 3 out of 5 days. I travel on one day. And then we have a rural hospital in a place called Reedsville, which I do a lot of complex cases, the big stay overnight, brachioplexus, TMR cases. And then I do most of my cases as outpatient in our ASCs.
Awesome. So obviously you do a lot of really great hand surgery, microvascular, really complicated stuff. But you also have that engineering background. You talked about the company that you were initially with that just, obviously you did a lot of work for them and didn't get the same recognition that you wanted to. And then you came up with some ideas, right? So you co-founded this company called MicroC that's now Oxos. Will you bring up that slide? Will you kind of go through that background of like how that started? What was your reasoning for that? I mean, we can make some aspirations of this, but I'd love to hear it from you.
Well, there's actually two stories that come to mind. The first, I was in Honduras as probably a 4th or 5th year. And we're in the middle of the jungle and we're seeing, 400 or 500 patients a day. And we never had X-ray. I know that we used to go down there with the dental students, and they had this small dental thing that you could probably take a picture of the tip of a finger, but that's about it. It was built for taking a picture of a tooth, and it was battery powered. And I remember thinking then as a 4th year med or a 4th year resident, like how cool would it be if we could expand this to a larger field of view, make it battery powered and portable. So that was really the first time I thought about it. And then when I got in the fellowship in Boston, I was doing a hand replant, literally like replanting a hand one night by myself with an intern. And the hand literally kept falling off the radius. Like I was trying to plate it, and I had the intern who didn't want to be there, and I'm trying to turn a screw. Because first step of any replant is get bony stability, right? So I'm trying to hold this dorsal plate, spanning plate on the carpus and the metacarpal, and I'm like, hold it, and I'm putting the screw in, and the thing just kept falling off. And I'm trying to bring in this 800-pound X-ray. We had the big C-arm, and I kept knocking the nurse over. I mean, it was 3 a.m. I was tired. I was up all night. I was like, man, it would be really cool to have something I could just literally, like a camera, just shoot a picture and not have to bring this 800-pound C-arm in. And my light bulb went off. I'm a little bit engineered and ADHD, I guess. So then I finished the case and then immediately went to a lab and started thinking about how I can miniaturize a C-arm. And then I took that 800-pound C-arm and built this. This is like an 8-pound battery-powered. Now this will do. I mean, this as a 9-inch tech, this will do everything that big C-arm does. It is fantastic. So we were able to miniaturize that, and we realized is that, you know, miniaturization is not all that it's all that it seems. It's a giant. And if you guys want to dork out with me and get the engineering of how we had to do that, I'm happy to do that. But it becomes a giant heat transfer problem because you're taking a bolt of lightning. I mean, imagine 90,000 volts. That thing will go up to 88,000 volts. 90,000 volts of electricity are going through that thing. So it's a bolt of lightning.
So is that the same thing that happens in a large C-arm? It just doesn't take the same amount of heat. So like, how is that different than?
Yeah. So that's okay. So this, I'm glad you go on that. I didn't want to be that guy that totally dorks on you, but okay. So let me give you an example. Okay. So let's say you take a frying pan. It's with burning oil. You could throw that into a bath of water and cool that frying pan off pretty quickly, right? That's a good way to cool off a frying pan that's hot and it's going to hurt somebody. So that's a cool way to dissipate heat quickly. You can't. That's kind of what a big C-arm does. They pot the X-ray tube in what's called dielectric oil, and dielectric oil is extremely heavy. So that's why those things are extremely heavy. So they're essentially throwing a boiling, like a hot frying pan into a pot of dielectric oil. Ours is a little bit more sophisticated. We had to be really creative because we don't have, ours can't be really heavy. So we had to be, ours is 8 pounds. So we had to use really sophisticated heat sink transfers and what's called phase change heat sinks, which I can really nerd out with that one. But essentially we had to come up with a really unique way to spit off heat quickly, because when you shoot an X-ray, 99% of the energy is given off as heat. And when you've got 90,000 volts going through your hand, you've got to shield that high voltage electricity from the low voltage, like the PCB board, your motherboard, all the stuff that runs your electronics is low voltage, right? And that's probably 2-3 centimeters away from a high voltage tube. So when you shoot high voltage, all these eddy currents are given off, and they can really shock and like basically blow up your low voltage PCB board or your motherboard. So we had to do potting, shielding, heat transfer, all these really like material science things to make it safe, and then also to give off heat. And then we had to do all the other things about like focusing the FDA, the first step is you got to make it safe. You can't kill anybody. You got to basically harness a bolt of lightning in your hand and not fry everything that's low voltage. That is a conversation for another day. I'm happy to have that conversation, but that's a lot of material science that we had to figure out. But then second, you got to focus the X-ray. So when you shoot an X-ray, you can't just shoot into space. The FDA won't allow that. You can't just shoot free photonic energy. It's unsafe. The photons have to be focused on the detector. So we have a collimator, which basically conforms like a lens. It focuses the beam. So think about it. When you're far away, you can see my hands. When you're far away, the beam is real narrow. When you're close, the beam is flat. When you're kind of off to the side, the beam kind of skews this way. So we have a collimator that's contorting the shape of the photonic beam in 3D. So the detector always has to know where the emitter is, so they talk through LiDAR.
Do you have a detector on that device, or how does that work?
Yeah. Oh no, some of the ones that you'll get from Japan, or the cheaper ones, they don't have a detector. So they sell you this emitter, and then you got to go buy a $100,000 detector. And they don't always I don't know. We didn't want to do that. We wanted to do a whole focus system. So the detector will talk to the emitter, and they always talk and we, to satisfy the rules and regulations of the FDA, we had to create all of this new technology that we've patented similar to driving car. Like when you drive a car, it's using LiDAR to tell you where you are in space. Our detector and our emitter always know where they are, so you're not spilling radiation off the detector. And they have a stop out. So if I take the detector and point it at your face, it'll lock me out. I can't shoot it at you. It knows it's not coordinated with the detector. So
you need that detector to show where it's going. Yeah, they always have to talk. And if they're not focused on it, if it's in a position where it can't focus, it'll lock out. And that's how we were able to satisfy having it move in space. And that was a really, at the time, we didn't have a lot of technology. I mean, back in 2016, 2018, we started that. Like the technology had to sort of catch up to our innovation. So we were able, I had these brilliant Georgia Tech engineers. My friend Evan, who's our CEO now, he and I were really, really kind of going outside the box on this because the FDA put up such a high fence, they were like, okay, the only way you're going to be able to get a handheld device is if they talk and move and it's locked out, and then it's extremely safe where it doesn't blow up and hurt anybody. So they made it extremely challenging for good reason. I mean, you want everything to be safe. So it was an extremely challenging feat of engineering to get this thing approved. And how did you test it? It's like, are you testing this like in a room? Like, how do you test it for the radiation dosage, et cetera? Oh, well, we built a radiation room that we some of the tests, so they do drop testing. You got to drop it from a certain height. You got to fatigue it. You got to shoot millions of x-rays, just keep pop, pop, pop. So we have these lead line rooms where we just keep shooting x-rays. And we have these these meters that just literally, they add up all the dose, they add up all the fatigue stress on everything. So yeah, we beat the heck out of it to satisfy the FDA. And there's a company called Intertech, which helps us with the imaging. With the testing. So hats off to the FDA. They make it challenging for a good reason. But yeah, it was really difficult to pass their test. So, the thing is extremely safe. And this is your first version, right? This was the initial one. You got that new one coming out. No, we're at MC2. The first version was actually our alpha version, which, one thing that we harp on in any company is customer discovery. Pull that up well. Yep. Yeah, that's our second version. So that's completely battery powered. It's got a pretty long battery life. We use that thing for pro sports teams. I cover a hockey team. We use that in a hockey locker room. We use it obviously in our rural clinics. I think one of them's going to Bangladesh next week. It goes all over the world. I've taken the first version to Africa twice. But yeah, it was funny because my first version, I took it to Mombasa, and I was going through TSA, I was going through security, and the lady thought it was a bomb. So she actually, there was a language barrier. I'm serious. They brought guys with like loaded rifles, and me and my wife were like, it's not a bomb, it's an x-ray. And there was a language barrier there. So I actually had to plug it in and show that I could take an x-ray to prove to them that it was safe. They didn't know what it was. So it's really cool to be able to take an x-ray unit abroad on a plane, because you can take it on these mission trips, which was really, really helpful. We couldn't have done any of the surgery that we did without that. So it was really helpful. But yeah, we use it in rural clinics. I use one in my office because it helps. We have an x-ray suite as well, but having it in my office allows me to do x-rays and streamline the things. And then I can do DDR and fluoro and all that other stuff too as well. Yeah. So explain how explain the DDR to the patients, the dynamic digital radiography, and versus explain how the difference is and what you use it for. Yeah. Okay. So you guys probably all have a 4K TV. It's really clear. You're watching movies like never before. But some of us are old enough to remember the analog TVs, the ones where the big old heavy ones with the cathode on the back, the ones where the quarterback would throw the football and there'd be a streak behind the ball. Remember those old TVs? So those were the analog TVs. Fluoroscopy is kind of like analog. The X-ray is just on. So that's why when you move the shoulder or the wrist, you see this blurred, we call it motion artifact. So that's kind of like the old analog TV. It's basically the X-ray tube is just on. And whatever sort of vibratory or motion effect you get kind of a blurry image. You guys have all used
C-arm or fluoroscope to know that that's called motion artifact. That really bothered me, particularly in small joints when you're trying to look at like a scaphoid or where the screw is or where your K-wires. So there's been this big push for DDR. DDR is like a 4K TV. So a 4K TV is basically a bunch of still images stitched together at a high frame rate. So the reason why a 4K TV is crystal clear is because in some cases it's taking 60 images or more per second, and it's stitching them together like a flip book. You guys have all remember the flip book from grade school? Little stick figures that they move and you're flipping it through. So DDR is basically pulsing, shooting X-rays at a frame rate, and then it's stitching them together for a video. So you get a crystal clear image without any motion artifact. And there's two reasons why DDR is better than fluoro. Number one, you pulse the X-ray, so you don't just leave it on. So you're not just...
Is that less radiation?
100%. So the dose is the area under the curve. So if you look at the dose, if you think of like, and I'm using my hands here, if you look at like the radiation dose from time zero, it's just on. So you're getting all this dose underneath the curve.
Yep.
DDR, you're pulsing it. So you're basically taking a bunch of lines and sticking them together. So the area under your pulse DDR is far less than fluoro. So DDR is sort of a way to get a clearer image with less radiation. And there's some companies, I know Konica Minolta is big into DDR. That's going to be you're going to see a lot of companies coming out with DDR. It is, you get a far clearer image with safer radiation. Plus you can stop it. What I like about that is you can actually, I mean, if you see our device, you can roll through the images and just stop at whatever image. I mean, you guys have iPhones.
Oh, I see what you're saying. So you're not, before you do live fluoroscopy, you can't stop at a certain point. You're like, okay, stop right there. And then they stop, but it doesn't always stop in the spot. Yeah. You can go through your old like pictures. It's like basically is like the iPhone where you like take like 20 photos and then you can skim through and stop at the one you want.
100%. So if you took a video from your iPhone, you can just scroll and stop at that picture and then like splice that picture and print it. So you're taking a bunch of still pictures and stitching it together as a video. So yeah, it's the difference between an old analog TV from the 1980s and a 4K TV. So if you see it, and hopefully you guys, if you go on our website, there's a bunch of like crystal clear videos. It is literally like looking at a movie of a skeleton. It is crystal clear imaging. And one thing that I don't want to oversell it, of course, because no one ever believes that, but you just have to see it to believe it. And I think one of the comments that we always get is I can't believe how crystal clear the DDR is. So I mean, I hopefully you guys will see it.
Do you with this product, do you from a patient or from a standpoint of like obviously clinic efficiency, right? Like if we got 4 providers in clinic and you have 1 X-ray machine, that's pretty slow, right? And there's certain aspects. Is there different, like when we looked at new machines in our office, there were certain specialties that it was more beneficial for, like hand. The smaller machines were better for, but like I do shoulders and knees. Is that the capabilities of this device, or is this mainly for the hand extremities? So
we're submitting a new clearance for larger anatomy. Everything needs to be cleared by the FDA. So shoulder and hip and shoulder and knee are on that. But you know, it has the same power to do that. Now we have to convince the FDA of that, of course, but that is on horizon. So
right now in your clinic, foot and ankle, and can foot and ankle use it, or is it mainly hand?
Foot and ankle and elbow down. Yeah.
Okay.
And so what I like it for is the fact that, okay, so, you know, I want to get a quick, so let me give you an example. Instability is a big part of my practice. Anybody that does revision stuff or second opinion is going to get an SL tear, right? Just like you're going to get a labral tear, right? Anterior labral. You want to see dynamic stability. So you want to stress the arm and see if it kind of comes out.
And we can't do that right now because it's too much radiation for somebody.
Yeah. So ours is, well, I mean, we have all kinds of studies.
We can't go in the office and do a fluoroscopy of somebody. It's just not like versus being able to bring it into your office like that. You know what I mean?
Sure. Well, so we have remote triggers. So there's a foot, so you don't have to be right next to them. Now we can argue about, you know, the radiation exposure and everything. But like for me, getting like when someone feels a pop in their wrist and they're a young guy or young athlete, particularly like a hockey player or like, you know, football player, I worry about SL tear because you don't catch that early. Then you start getting DC and SL diastasis, and then you miss the opportunity to fix it. And you probably remember from residencies that chronic SL tears do terrible. Probably like a chronic, you know, bank heart that was missed probably will do terrible. You're going to get glenoid wear and all kind of problems. So, if I can catch an SL tear the week of and go fix it with like an internal brace or something, they're going to do great. So the problem
you said Will's favorite word. Be careful.
Oh,
internal
sorry.
brace.
Oh, I love. Oh, okay, I won't.
He loves that. He gets too excited. He starts.
Oh no. Well, I mean, I'm very fond of Arthrex, obviously, but my point is, if you catch it early, like it's a difference between a salvage procedure like a PRC and having your wrist back to normal within a couple months, right? I mean, it is really like, and the problem is the X-rays are normal, so you get a still image and it's normal.
So you need dynamic.
You need,
right?
Yeah. So what I do is I go in there. So I don't even bother taking them over to. I mean, I don't even bother taking them over to my X-ray and get a still image because it's not going to tell me anything. I can do a clenched fist view, but even that can be. So what I do is I just say, look, I want you to do this back and forth, and then I'll hit the pedal, and they'll just go in like this. I'll be, across the room, and I'm staring at that big screen, and I'm looking, boom, that the scaphoid is flexing and the lunate is extending, and they got clear DC, and you see the diastasis. And the DDR is so clear, I can literally stop on that image and show where the diastasis. So that's a big plus for me. And there's all kind of billing parts for that, right? For like DDR versus static. But my point is that's a big. And then you probably work with elbow. I look for Tommy John, ulnar collateral ligament. The other thing I like to look for is MCP and particularly MCP instability. That's one that's often missed. Or fracture dislocations of the PIP joint to see where it's stable. I mean, some of those are real stable if you just, do an extension block pin or even like a splint, you can get away without doing surgery. But to know where they're unstable is really helpful when you're doing DDR, because you can just sort of take a freer or even your finger and just do that, and you'll see when they come out. And then elbow dislocations, that's another one. I put them flat on there after they come in with an elbow dislocation. If they're not super swollen enough for me to test them, I kind of look where they just come out. If they're coming out like 30 degrees, I'll put them in a dynamic splint, say full flexion to like just at 30 or maybe a little bit before then. And then, so I can get a DDR of their elbow and find out right where they're coming out. And I can sort of brace them and I can harbor conservative treatment by just watching them to see where they become unstable. So DDR has really changed my practice because it's giving me all kind of things to know where their actually dynamic instability is. I think shoulder is I don't do a lot of shoulder, but a shoulder would be extremely helpful particularly for laxity, whether it's posterior, anterior. I think it'd be extremely DDRs would really help a shoulder surgeon.
Well, we don't have that. I mean, most of the time, I think I have a question for you. I mean, this is something that in fellowship I did where I went to HSS for residency. We had a lot of good hand surgeons that did some of the crazy surgeries you're talking about, brachial plexus, et cetera. But to dynamically see it in the office is very uncommon. We just didn't have that diagnostics tool set. So you're basically allowing you to diagnose a whole nother set of things faster than you would have been able to do before that. I mean, because before, what were you doing? You weren't checking that, or were you even doing anything if you didn't have it?
Well, so I don't know about, well, MRIs are disappointing in many cases. I can't tell you how many times I've gone in and scoped a wrist or an elbow thinking I'm going to see X when I really see Y. I'm sure in shoulder, you go to a scope of shoulder and the rotator cuff's completely fine and you think it's torn. That happens a lot. For DDR, particularly with fractures, you really kind of find a point of dislocation, which actually really helps me with my pre-op plan. And the one thing that I've always, so I get a lot of like high energy TFCC and DREJ dislocations. You're going to find out where to even splint them. And I swear, I've done hand surgery for 10 years. Sometimes I even get confused. I'm like, do I splint them in supination or pronation? Which ligament is torn, and you kind of know the textbook stuff, but like you just want to see it pop in and become stable. So what's really nice about this for a DREJ dislocation or TFCC injury, I can actually find out where they become unstable. It gives me an idea of whether the volar or dorsal complex is torn. And can't tell you how many times I've gone in and I had an MRI which said that this was torn, and then the DDR would literally like blew that out of the water. Like the DDR completely did not match, the dynamic stability did not match up with the MRI. So if I would have treated the MRI, I would have got the wrong outcome. So DDR is really, if you can do it and you can fit that in your practice, it will sometimes kind contradict an MRI result. I think MRI sometimes we over rely on them.
Yeah.
Seeing a joint where it wants to be, particularly in a hand and wrist, it's so easy to do, especially if you've got this in your clinic. It's really made me not go down the wrong path in some cases.
Well, I think it's also, like you keep saying, it's better for the patients, better for the clinicians, because I find that, and I think we'll attest to this, that if you can have a better preoperative expectation for your patients, that's a big deal, right? Like if you're like, I'm going to go in and do this, and they wake up and they get that,
Sure.
That's usually the people that are very satisfied with their outcome. Even in comparison to people, I get second opinions, thirds like yours, and they come back after surgery and they're like, a doc said I was just going to figure out what happened inside, right? That outcome's not usually the same, or it's not as frequently as good as if someone's like, my doc said I was going to get this and I got this and I feel really good about the thing, right? You're basically giving them more information ahead of time and they're feeling more confident diagnosis, not only from the patient interaction, but also now the interaction between the doctor and the patient.
Well, I mean, think about so we always say you can teach a monkey to operate, you can't teach a monkey when not to operate, right? And that's really the hardest part of our job. Once you learn all the surgeries and you're at that point in your career, the hardest part is learning when not to operate. And I think for me, like if I have someone like say MDI, like a young girl with a high maintenance family, you don't want to operate on someone with MDI. You just got to kind of coach them through it, right? So if I can show them safely that, their elbow's popping or it's hyperextending and it's clicking, or their shoulder sort of the sulcus sign, if I can show them that and they can actually see they can see the head popping back in and that it's not hurting her because she's not wincing, that does a lot of good for the patient and her family. You can say, look, they're popping out like without me hurting her. And this is just who they are. And I think that's really helped bailed me out of some difficult situations where you've got a patient who's complaining to their mom that they hurt. They don't need surgery, but you got to convince the family that they don't need surgery. So DDR is really helpful in that case. And I think ultimately, like I had a young patient with an elbow dislocation, and the mom was really asking me why I don't do surgery. I was like, well, the body can fix. I mean, the ligament's torn, but it's going to heal. The LUCL is going to heal. Let me show you. And I was literally showing this lady. I blocked her a little bit to make her comfortable. And I could show how the elbow would sort of come out and pop back in. And I said, this is why we're going to splint you to here. And in 2 weeks, we'll go a little bit further. And every time you come in, we're going to go a little bit further as that ligament heals. And this avoids surgery. It's not going to create scar tissue. And you'll get to where you want to be with extension. That really, because the MRI is always terrible, right? The MRI says a million things are torn. They come with the report like, you need to fix this. Your LUCL is torn. There's a non-displaced coronoid fracture. And the MRI just shows all these things. And you're like, none of that stuff needs surgery. That will heal in a young patient. Let me show you. So DDR can be a really nice tool to sort of walk them back from insanity, right? Like, why are we operating on this poor kid that's going to do well if we just treat it on up?
You mentioned that you've worked with sports teams. How has the DDR been helpful and impactful with teams, and how can you see the future of DDR supporting teams, whether it's professional or college or local? Does it become like almost like a on the field triage type of situation? Can you explain a little bit about that?
So hockey players are animals. Hopefully you get a chance to take care of a hockey team. Those guys are the toughest. I take care of minor league hockey too. So these guys are so tough. They're super nice. They just want to get back on the ice and hit somebody. And in some cases, you have to be like, I'm using DDR to like pull these people back. In some cases, I'm like, look, you're unstable. We got to stop. Because these guys will literally go back, if you give them any green light. So for me, hockey, you'd be surprised how many hand and wrist injuries they get. I see a lot of forearm fractures, finger dislocations. I don't know how they dislocate their finger. They're wearing gloves, but they do. I see a lot of rib fractures. I think as we get more advanced with DDR, like looking at like shoulder instability, cervical spine, I think it could be extremely helpful in the cervical spine, lumbar spine, as we get more sophisticated DDR techniques.
Would someone like you need to be as skilled as you would need to be that person that's operating this machine, or to be something as far as like just the team doctor? Like, what's the level?
No, I don't shoot. The AT does it, the athletic trainer. Um, I'm usually like, sometimes sometimes he'll be down there shooting it, and then we have this little walkie-talkie. He'll be like, "Come in the room. I want you to look at this." Or sometimes we have a platform where we can see the X-rays live. Or we have all.
Oh, that's
we've
pretty
made
cool.
it extremely easy. I mean, we can remotely see the X-ray. And we can see the DDR remotely. So even if you're not at the game, like those images can be shared securely to the team doctor. So we really try to make it extremely easy for the team doctor, because sometimes you're not on the road with the team and you need to know what's going on. So we definitely take remote access and portability to another level, of course, because you can put it in a suitcase and take it with you, right?
So that's pretty cool. So you can be the team can be getting on a game. They injure themselves. They call you and say, "Hey, doc, I want you to take a look at this," and you can literally watch them do the DDR.
Oh yeah, we have a secured access. Yeah, we can log in and look at it.
That's pretty cool.
Yep,
that's really cool.
Middle of the night doesn't matter, especially if they're on the West Coast.
Yes. Chu, we want to, in the sake of your time, I know it's getting late, we want to kind of know for you, what's the roadmap for this technology in the next 5-10 years? Sure. What are you guys thinking?
Our goal is to make it more powerful. We definitely we know there's a lot of need in larger anatomy, so we need to get a more powerful X-ray. So we've had a lot of patents around the monoblock. We need to make it more powerful. We want to get a bigger detector to cover more anatomy. Those are the next goals. We have a lot of special vendors. I can't really say who they are, but they have certain needs, particularly for Department of Defense. You can imagine how important it is to be able to get, a chest tube or a central line in the right spot.
Yeah.
I mean, at the beginning,
and you can't do that. You can't have a C-arm dragging in there with power.
Well, I'm talking about putting one on a flight, on a helicopter, or like
my point is that you couldn't do that with any of the
current
devices.
So we have a lot of aspirations for home care. We hope one day that we can. I don't know if you guys have children, but I have 4. And if you've ever been to the ER on a Sunday with a kid with a presumed broken wrist, it's a miserable experience.
Yeah.
It's also very costly. So we hope to, because it's so portable and safe, we hope to be able to dial up an X-ray where you can have one of our technicians or one of our associate portable companies come and shoot the X-ray, and then not only get you diagnosis like at the point of care, like in your home or on the sideline, but then also triage you with someone like you, Dr. Garcia, and then or someone like me who can then get you an appointment that day, right? So you might be sitting, at home on Sunday. You might get a text and say, "Hey, there's a patient in your area that would like to see you for a proximal humerus fracture," and you can just use our user interface to go and say, make that person an appointment. So, using technology will be able to help you as a surgeon work smarter, not harder, where you don't necessarily have to take these calls and, put yourself out there and cover all these ERs, where you can just use technology that's out there doing it for you. And just being an early adopter, you can increase your referral basis and you can start triaging people, because it's going to be cheaper and safer, right? I mean, I had a $4,000 bill from a both bone forearm fracture on one of my children. It was also 4 to 6 hours of waiting. Not a great experience on a Sunday. Ruined my weekend, actually. But I mean, it is what it is.
Especially when your kid is in pain and you're helpless.
I mean, really, like for me, like she wasn't even that much pain. So like, I just need to get her in a splint and I need to get an X-ray. So I know like what's going on. So, and I need to get her an appointment. I mean, so I want to get her one of my partners. But I was out of town, right? So you had to do what you had to do. But so we hope to sort of streamline the process by making it safer and faster, but basically bringing portable X-ray to the point of care.
Yes. Yeah. And right now you're bringing up kids, and I want to sake of time, wrap it up for you, and then make sure you can go home and go to sleep and relax. But is this approved? Can you use it in children right now, or is that next step for you with FDA?
I believe that is on the this application. The current one.
Cool.
Great. As we wrap it up, first off, once again, thank you for your time. I want to know where your allegiance lies on Saturday. Are you, John the Farmer? Are you a Pilgrim? Or you Yellow Jacket? Or you a Buckeye? It's very confusing. We need to know where's your allegiance.
Well, my Georgia Tech Yellow Jackets are 9-1. We barely beat Boston College. Our defense has got some work to do. But everyone, I live on an island off the coast of Savannah. Everybody's a Georgia fan. So, but I also grew up in Ohio, so I'm a big Ohio State fan. And Ohio State's they're actually a big proponent of our technology, so they've been great to us. So, yeah, I would probably, Ohio State is always been, I've always bled scarlet and gray. But it's nice to see Georgia Tech, which is not traditionally a great football powerhouse, although we have a great history, to be 9-1. I just hope we can hang in there with Georgia. If we beat Georgia, that will be my national championship.
Are you going to be okay with your friends there? If
no, I'll wave my flag. I'll wave my white and gold. my white and gold flag will be out there all year if we beat Georgia.
That's great. Dr. Kolovich, thank you so much for your time. We really appreciate it. It's really informative. It's exciting to hear where the technology is going. And it seems like there's a lot of possibilities for someone that has done work in Dominican Republic. My wife is in Nigeria right now. Just hearing that you're traveling and helping out these communities, I know how difficult it is. You're usually working in conjunction not only with the locals, but also their politicians. And sometimes you don't even have, you're not even able to go into certain places without telling someone, where it can get pretty hectic and scary if you don't abide by their rules. So just hearing the work that you're doing out there, it's heartwarming. So I personally want to say I appreciate hearing that from you.
Well, thank you. I really appreciate that. And I that in the end, I create an X-ray for the purpose of helping people. Really, it's really what it's about. And we stick to that mission every time. And we really do enjoy doing mission work. It is the icing on the cake for us.
That's great. Thank you. Dr. Garcia, it was great having Dr. Kolovich. I mean, the possibilities are endless, right? I was even thinking about the wilderness first responders, right? They're coming in their helicopters.
There is so many options for this.
Yeah, you have people training. They could do some of these imaging beforehand. So then by the time they get to the hospital, they already kind of know what's going on. They identify, especially when you have an injury out there in the woods that can be, extremely dangerous. Every second counts, especially if you have a tourniquet or anything, right? So just hearing about stuff like that was one of the things I started thinking about along those lines. Let's do it. Hey, check us out, Sports Doc Talk. Catch every episode, transcripts. We'll have a transcript of this show. You want to be our next guest? Reach out to us. We're extremely thankful for all of our viewers on YouTube, for everyone listening on different platforms, whether it's Apple and Spotify and iHeart and everything else. We just want to thank everyone for joining. We hope that you're learning something. That's really the reason that we kind of got into all this, besides us talking about the Giants and what kind of miserable fans we are. But besides that, we're really happy to provide great information, great guests. Last words, Dr. Garcia.
Well, great guest, really cool technology, really going to be next level for us, just showing doctors we still have a void in diagnostics, right? MRIs are great, CTs are great. This is a new pattern of things we haven't really got into, and easier to use than something like ultrasound machines, easier access, faster. So all these things are going to improve for patients. But really the key here is, as you keep hearing, it's patient first. Fix the problem, find a solution. So anyhow, thank you so much, Dr. Kolovich, for coming on, and thanks, viewers. Appreciate it.
All right.